name is Jo, and I am from the COBRE, which I'm going to tell you a little bit about in a second, and then I'm going to be handing it off to Juliette. First, welcome to the webinar, Harm Reduction, Improving Health Among People Who Use Drugs. This continuing education course is hosted by the Center of Biomedical Research Excellence on Opioids and Overdose, the first center of its kind that addresses the opioid epidemic. The center brings together leaders from institutions across Rhode Island to support the research needed to combat the opioid epidemic that is hampering and taking the lives of our friends and neighbors. To learn more about the work we're doing, please go to our website, www.opioidcobre.org. All right, so I am going to now hand it over to Juliette.
Hi, everyone. My name is Juliette. I'm an LICSW and LCDP. I currently work at Rhode Island Hospital. I think I see a lot of familiar names, so that's good. I'm one of the addiction medicine social workers. So today, our topic is a really good one that can be used in any kind of treatment modality as social workers, outpatient, inpatient, all that good stuff. So harm reduction and overall improving the health among people who are using drugs. So I have no relevant financial considerations to disclose. So I just want you guys to kind of think for just 2 seconds, a patient of this kind of narrative, and then what feelings kind of are brought up. So a patient with a history of opioid use comes into the hospital or into your primary care office, and he wants to be treated for cellulitis. So I'm curious, what emotions does that kind of generate? And why? There's many contextual factors that kind of contribute to maybe having some bias, feelings, emotions, and listed below are a lot of ones that can kind of be considered, which is, your professional training as social workers. Is it your work policies? It could be your own personal experience with addiction, whether that be, individual, it could be within your family. And just previous experiences overall working with this population. So we're just gonna watch a quick little video and then we'll kind of move on, but I kind of want you to guys see this and really think about what kind of pops up for you.
I really felt the stigma of addiction. From everybody. I wouldn't go to the hospital just because I knew that as soon as I got there, as soon as they looked in my chart and saw that I had a history of heroin addiction or saw the abscess in my arm, I was instantly labeled a junkie. I was left in the hallway for hours, asking for a glass of water. I'd be ignored for hours. Even when I went there for something that had nothing to do with pain and I wasn't requesting pain medication, they would automatically think that's why I was there and tell me that before I even said anything, don't think you're getting any narcotics from us, and it's debilitating. It kept me for a long time anyway, from getting treatment. I was afraid that everybody would think I was a junkie and a disgusting, dirty person. That language, clean or dirty, or even the word addict has so many connotations to it that it's just it's sad, and it's killing people. It's literally killing people because it perpetuates the stigma and it prevents people from getting treatment.
So yeah, I think Stephanie's story, we can all relate, especially many of us, I think, here in today's webinar, work in the hospital setting and can kind of relate to that story a lot. So these are our learning objectives that we're hoping to kind of point on. So we're going to evaluate harm reduction interventions for patients who are using substances, articulate the effect of and the importance of person-centered language on the care of these folks, and just overall explaining the difference between what is substance use and what is a substance use disorder, because they are two different things. So first off, let's talk a little more about what harm reduction actually is. So harm reduction, obviously, it's a set of practical strategies and ideas, and ultimately we want to reduce the negative consequences associated with drug use. And harm reduction doesn't necessarily mean complete and full abstinence of substances. So it's a movement that's built a lot on social justice, having a lot more respect, having reminding that these folks have autonomy to choose what is best for them. So the huge motto for harm reduction is meeting patients where they are at and not leaving them behind. And what that ultimately means is, if you have a patient or a client and they are not completely ready to stop using, or they're willing to stop using one substance but not another, saying that's okay, and kind of working with what they're kind of giving you and what they're ready to work on. The secondary one is giving and maintaining recovery capital. And what is recovery capital? Because that was a new term for me recently. It's basically, it's a conception, it's conceptually natural recovery. It's solution focused, it's strength based. So it's a lot of case management, it's a lot of resources, it's a lot of identifying what the patients have in terms of resilience and protective factors. So in recovery capital, there are actually 3 types of recovery capital that I just recently learned. So there's personal recovery capital, which is, you know, the physical stuff. It's the basic needs: clothing, shelter, those kinds of resources, food, a safe place to go. And then the secondary is family and social recovery. So that's more of what is their intimate relationships look like, who's their supportive network, and how can we use these as a resource for them to get well. And then lastly is the community recovery. So those are the attitudes of the community, the attitudes of the state, policies, procedures, what are the available resources to help you guys when they're feeling ready to take the next steps in recovery, or at least in harm reduction. And then lastly, another obvious important aspect of harm reduction is really understanding what is the underlying issues driving the actual use, and kind of working with that to then start motivating the patient to then maybe lessen their use, to maybe hopefully reach the goal of maybe complete abstinence. So harm reduction is not enabling. I think this is a huge misconception that a lot of people have, especially when we start talking about the actual techniques and resources for harm reduction. It's a way of motivational interviewing. It's a way to start planting seeds and working and building rapport to get somewhere where we want our patients to be at. It's not abstinence only. So like I said, some people will maybe still drink but not use heroin. We're not always looking for abstinence. We want to meet where the patient's at and what they're willing to work on. We also can't assume that all substance use is problematic. And I think this is really hard for us in maybe a hospital setting or a primary care setting, because when we see positive UTOXs for something, or they're here for an accident because of intoxication of some sort, many people kind of assume that, oh, they must have a problem with it. And then lastly, another huge thing is harm reduction is not one-sided. Again, it's meeting the patient where they want, where they're at, and that they have autonomy. That it's just because I would like you to be abstinent from all substances doesn't necessarily mean that's what they want. We don't ultimately know what's best for the patient. It's up to them. They're the experts in their body and in what they want to do. So these are our social work core values. I'm sure many of you are very familiar with them. I like this slide just to kind of remind us what our values are, but also how we can use them in working with this particular population. You know, we're here to serve. Lots of social justice issues with this population. Reminding ourselves sometimes that these people have dignity, and they are worthy of services and worthy of having support. In addiction, it's so important to have human relationships, having that human connection with people, so that when they're ready to move forward, that they have those supports in place, they have integrity, and that we are also working, you know, within our competence. If we're feeling like we don't really know what to do with substance use disorders, whether it be resources or medications or anything like that, knowing when to stop and best ask for help. So here are the discipline-specific roles in healthcare that we want to touch upon, especially with harm reduction. building trust is a huge one. Taking small steps to build that quick rapport with somebody and kind of hopefully maintaining and having a consistent relationship. Of course, working with a strengths-based approach, identifying what has worked for them in the past. Why do you think it worked for them? And really just kind of validating and encouraging them to remember their strengths and that they're resilient. And then working towards what is the patient's goals, not our goals, but the patient's goals. And then how can we work in little mini bite-sized chunks to get to their ultimate big goal, whatever that may be. It could be full abstinence, it could just be decreasing their use. So here are some paradigm shifts that we're going to talk about and review that are very centered to harm reduction. So we'll talk a little bit about person-centered language, which is important, how healing is important, and that we're not trying to paternalize our patients or clients with addiction, and how can we reframe metrics, which is what is their quality of life and how can we get there. So non-judgmental. This is, I think, our social work basis or counseling basis. You know, we always try and come in with an approach of being non-judgmental, and that we want to remember that just because somebody has a substance use disorder doesn't mean that that's what identifies them. They are much more to that. They are much more complex than that. And remembering there's a story and a narrative behind each person that you encounter with a substance use disorder. So many factors come into play to that creates this person to where they are today. So life circumstances, health, adverse childhood experiences. So, you know, longitudinal services can kind of get more into the nitty gritty, where maybe hospital social work, we have very time limited and we don't want to open too much trauma boxes, but, you know, abuse, neglect, domestic violence, did their parents have drug addiction issues, mental illness, and kind of just seeing how that kind of played a role in shaping them who they are today. Healing, not paternalism. I think this is also one of my favorite topics, just because I think working in a hospital setting, all my patients get seen by a multitude of different types of people, doctors, nurses, specialists, and I think it can be really hard, especially for me too, not to want to parent them or tell them what to do. So we have to remember that it's all about the healing process. And the healing process is, again, really kind of figuring out what is the underlying cause, really honing in on what is their goals, what does the patient want, and then working in conjunction, you know, as a team to achieve those goals. Recognizing and respecting that patients have agency. They have a choice in what they want to do and how they want to do it, with obviously our help and guidance to hopefully give them the right resources to do such things, but remembering that ultimately it's up to them. And what is their quality of life? What do they want? What do they see as a quality of life? It could be different than what I envision, but what's going to help them kind of step into the next realm? Being paternalistic, you know, we think that we know what's best for the patients, and telling them what they need to do, making decisions about treatment without their input, or not really explaining things. These things can be really damaging to the positive rapport that you build when working with those with substance use disorders. I think a lot of this, the last one, being upset when the patient fails to adhere to treatment, is huge. I think we can all relate that it really stinks when they don't follow through or have a difficult time doing X, Y, and Z that we put in place for them, but not trying to take that personally. It's not a personal failure on our part. It's how can we support and figure out what failed, what can we do to help them for next time. So reframing metrics. So this is again about quality of life. Again, our quality of life and what we envision for our patients or clients may be very different than what they envision. Reaching goals set by patients. Remember, it's the simple, small steps that can get us to the big goals. So really take and hone on those positive, small changes towards their goals, and really blow them up for them, you know, really praise them, encourage them, validate that they did this, even if it's just making a simple phone call to say, you know, 942 stop the sober housing grant. You did that on your own. I just had to ask you to do it and you did it, you know, really praising them. And really the simple one is just the patient keeps coming back. Even if it's coming back to the hospital a lot, which I know it's not great, but if they're remembering who you are as the social worker, even though they came last month and you're like, oh, they don't remember me, but they do, that's really big. That means that you impacted them in some sort of way. So take that as a win. And then systemic burnout. We can all very much relate to this as social workers or counselors in this field, regardless if we're working with substance use patients. We can all relate. We're overworked, we got high caseloads. There's a lot of time invested that we need to put into these treatment plans or getting people out of the hospital, dispositions, bearing witness to harm, in the sense bearing witness to maybe some people aren't ready for recovery, and we're bearing witness to somebody coming in the hospital or to a primary care place or your outpatient practice, and you just see the decline in them because of their continued use. Bearing witness to hearing their traumatic stories and kind of just taking that in, and it's exhausting. And you know, it can be hard to think about the wins when sometimes there's also really hard cases. So this is just, you know, the desensitizing and reprocessing. What is our intentionality? And then obviously a huge one in social work is self-care. Please seek out help. Please talk to your colleagues. Please talk to your supervisors or whomever you feel is a support to you that can kind of understand where you're coming from, because even not working with substance use patients, our job is really hard and it's a lot of work. All right, person-centered language. So person-centered language is huge, especially in our field because we're writing notes. But it also can be used as when we're talking to colleagues, whether it be doctors or our fellow nurses or our fellow colleagues, so that it's a way to educate people on a way to start talking about these folks in a more positive way, and then like kind of negative connotations, just like Stephanie said in her video. So what's interesting is compared to those in the substance use disorder condition and those in the substance abuser, agreed more with the notion that the character was personally culpable and that punitive measures should be taken. You know, so there's a lot of negative connotations with substance abuser, addict, alcoholic, junkie, and kind of just remember how that may make some people feel, but also how when you're kind of maybe doing a case discussion, how that receiving person is hearing and maybe perceiving the patient that you're trying to advocate for. I also like to say too, in like individual therapy or even in the hospital setting, asking what they prefer to be called. Some people are fine with being called an addict. Some people are fine being called an alcoholic. Some people are fine being called junkie. However, it's also something to think about, why do they identify that way, and maybe unlayer that, because and if that's impacting maybe their self-esteem. But it's also a way to lean in and align with the patient if it's okay with them to identify how they want to identify. So here's just kind of a really great chart to kind of show the difference between stigmatizing language and what you can actually say to replace that. You know, so a person is clean, you know, person in recovery, not actively using. I personally have started using return to use instead of relapse in my charting. And then substance use replacement therapy, that's really old school, but you know, treatment for medication for their substance use disorder, that kind of thing. So here's a really good example of some charting language where there are some negative connotations and how it implies otherwise, you know, so non-compliance, it implies that the patient, you know, when somebody is reading it kind of makes an automatic judgment for some folks. So it's something to think about. So, and I want to show you the one that is changed to the alternative. So Miss J is a 44-year-old female with a past medical history of substance use who presents with pain and swelling in her right lower extremity. She has been previously lost to follow-up in outpatient treatment, possibly due to housing insecurity. So it's just a different way. And I can say, even for myself, I have slip-ups. I'm still learning as well, just because you're taught one way and you're doing it for so long that sometimes you just need to have like a little cheat sheet. Sometimes I use that. So let's finally get into harm reduction interventions. So we have 5 listed here. So naloxone, the syringe exchange, fentanyl testing strips. But even all of these, we can also add onto medication-assisted treatment, or what we now are saying is MOOD, M-O-U-D, medication for opioid use disorder. So that could be even, harm reduction is even methadone and Suboxone, it could be antabuse, naltrexone, those kind of medications. So let's start with naloxone. I'm also known as Narcan. I'm hoping that everybody knows exactly what this is. So basically, this is just a medication that anybody can purchase now, and it reverses an opiate overdose. So it reverses the central nervous system and the respiratory depression that occurs when somebody is overdosing from opioids. And basically, it comes in 2 versions, an injectable and an intranasal. So the injectable is basically you either hit them in the fatty part of your arm or in your thigh. And then the intranasal is a half dose in one nostril and then the half dose in the second. It is not dangerous. It's not habit forming. So say somebody overdosed on benzos or something else, or they are assuming, like EMS is assuming it could be an overdose, and they Narcan them, there's not going to be any like bad side effects. And what's huge is it's saving loads of lives of those struggling with opioid use disorder, but it's also saving lives for those who are struggling with or just misusing like cocaine, because now we're seeing in Rhode Island and Massachusetts that a lot of the cocaine is laced with fentanyl. So even our cocaine users or recreational users are high risk for overdose. So this has also saved their lives as well. So anybody can, I would highly recommend you keep it, bring it to like, if you go to like music festivals, once those happen, or like concerts, something big, because you never know. I think it's really important, and it's really easy to access. And we also give Narcan kits in the hospital, so I can request one for my patients who are struggling with opioid use disorder. And so at time of discharge, they're handed a Narcan kit to have with them, which I think is great. So syringe exchange or needle exchange, this is a great resource. So basically, syringe exchanges are able to help reduce the spread of HIV, Hep C, Hep B. It's super cost effective, especially because if we are teaching our opioid use disorder folks safer practices on how to safely inject in a healthier way, they're less likely to come in with abscesses, cellulitis, or any other complications from IV drug use. Because the syringe exchanges that we have in Rhode Island, which in the next slide will show you what's available to you guys, is they have recovery support, people who are clinicians like ourselves. So studies have shown that participating in like a needle exchange program and kind of building those slow rapports actually show that there's an increased enrollment in actually getting people into treatment, because they're building a recovery network and they're starting to get motivated for change. There is no literature and there's no stats that show that receiving clean needles from an exchange won't actually increase the substance use, which is fantastic. And I also think this is a great way for people who may be kind of sketchy about this to show like, hey, no one's actually using more or getting sicker because of these programs. So here are just like the syringe exchanges that we have available. So AIDS Care, is great because they also have the mobile outreach van, and they also do delivery. They're very accessible, and they also have just a huge, a great support network for substance users, but also for those struggling with HIV/AIDS. Project Web Renew also has it, and they also have a mobile outreach. Also another great place for recovery, but also for anybody who may be in sex work that is trying to either get out or just need more support from that. And then the Serenity Center, which is in Woonsocket, that's through Community Care Alliance, and they also have a really great recovery center that also has meetings and stuff like that. So not only does these places have just give you needles, but they'll give you the Narcan kits if you want. They have fentanyl testing strips. They'll give you clean cookers, clean swabs, you know, alcohol for any like wounds for any if they pop them, that kind of stuff, condoms, all safe practices. So fentanyl testing strips. So these are relatively new over the last few years. So they found that, you know, these test strips are highly sensitive, so they'll pick up fentanyl. Patients, you know, they found that they'll modify their behavior if knowingly using fentanyl. I think nowadays in 2020 and where we're at with the opioid use, you know, epidemic, heroin isn't heroin anymore, it's just fentanyl. So this is just really great, I think, for any of our other drug users. So crystal meth has a lot of fentanyl laced in it nowadays, cocaine, any street pill like a benzo or a perk, oxy. We found that there's so much contamination. So if anybody is using any other substances, fentanyl strips are great. Just so that if you are just a recreational user of cocaine, like I said earlier, they can test their coke before they use it and then safely use if they know that it's without fentanyl, because they are very high risk for overdose in comparison. So this also just shows you kind of how to test it. So yeah, Project Web Renew and the needle exchanges, they also have those that they can distribute. You can also buy them on like Amazon and stuff like that. Safer injection practices is huge. And I talk a lot about this with my patients in the hospital setting, because this also can help reduce recidivism, again, for people coming in with complications from their IV drug use, like infections. So really educating them about having a safe environment. Is it clean? Is it dry? Because if it's kind of wet, moist, you know, those bacteria grow a lot faster, and that's what you're injecting into your body. Always using a new needle, always using a new syringe, always, you know, alcohol swabs are so important. Not reusing your needles, and also what kind of water are you using? There can be very, very, very dangerous infections when people use like old bottled water. So if like a bottle of water is sitting in your car for like a week, that water is yucky. It is very dangerous. And I've seen some really horrible outcomes from using bad water. So also a huge thing is rotating your injection sites, because that's also decreasing your risk for bacteria and infections. Obviously, hopefully staying just to your arms and not your necks, because that's when it gets even more dangerous. And honestly, really just an overall basic conversation about caring for yourself. Where are you going to shower? Are you using Shower to Empower, that program if you're homeless? Are you eating? Are you getting enough sleep? Are you actually following up with any of your medical providers so that we can continue to keep eyes on you and make sure that you're staying well? Safer consumption sites. So this is obviously a very taboo and controversial topic in America, because a lot of people would like to have these open, but I think it's a hard sell. So basically, safer consumption sites are supervised injection sites, just like the picture behind this slide. Somebody who's an IV drug user can go in. You get your own little kind of desk. You get handed basically a clean kit. So you have your cooker, you have a clean needle, clean cotton swab, all the gear. And and you can safely use there. And if you overdose, you are with a bunch of nurses and medical professionals that can assist. And what's amazing about these programs, so the big one in Canada is that they have recovery coaches, they have social workers like us, they have people who, you know, you just build a rapport. And what the studies are showing is those people are more likely to want to go to detox and then go to residential, because they're starting to build sober connects and networking and kind of realizing maybe there is more to life than using. What else can we do? These safer consumption sites don't show that there's an increase in use. It doesn't show that there's more overdoses. It actually showed that I think in Canada, they've been open for years and they've never had a death that has occurred in their site consumption site. And many of them actually have, like, the lower levels, the safe consumption site, the floor above them is actually a medical detox, and then the third floor is an actual residential. So when someone's motivated in the moment, they can kind of grab them and kind of go to the next step, which, as we know with these patients, they may want it in 1 minute and then something happens and they're on a run. So it's really fantastic idea to kind of snag them when they're ready. I also think overall it gives them kind of some dignity and respect, because, like I said earlier, in a harm reduction approach, you know, we're kind of thinking, hey, these people deserve respect and dignity. They don't have to go behind a dumpster or have to use outside in the cold. You know, we can do this in a safer way, whereas where they're being medically supervised to kind of use. So how to actually integrate harm reduction into your practice. So obviously harm reduction is compassion, it's inclusivity, and it's evidence-based. At the end of the day, I think the way that I kind of reframe it in my head is, if I had a family member who was struggling with substance use and was in the hospital, I would want them to be treated the way I would want them to be treated, and not like maybe a junkie or being just sat in a hallway for hours. It's how people approach you. So compassion, it's a holistic approach, you know, empathy, giving them integrity and respect, remembering that they're a person and that they're a whole person and that there's a story to them. Inclusivity is just, you know, coming in without judgment and taking care of all patients without discrimination. And then, of course, social workers love evidence-based practice. So harm reduction is an evidence-based practice. You know, we can use solution-focused therapy, strengths-based, all that stuff within harm reduction, to kind of try and get them to where their goal is in their next step. So obviously, this is an important slide, I think. And I would say I'm going to talk about the second point first, because I think that's huge. Because not all of us may work specifically with substance use folks, or maybe not in an environment where they're seeing them as often, but becoming more comfortable asking questions about substance use. Just being comfortable, not feeling awkward. It's how you approach it. Be curious, normalize it. Ask them, like, what's worked, what hasn't worked, where have you gone for treatment. You know, coming in with curiosity is less threatening than just being like, well, your detox is positive, or so are you using, or what, or going around the bush and hopefully that they'll be honest, or hopefully that they'll open up to you. And by being comfortable asking these types of questions and being curious, will then thus create a better working relationship with you and your patient or client. Building that quick rapport and maintaining it, and like I said, normalizing what they're going through and validating it will then make them more and more comfortable talking about what's going on with them. Of course, learning about what's going on in your state for resources to address this issue of theirs. Whether that be through a colleague who specializes in addiction, or using the internet, or using your government websites, just knowing more resources, the better, so that when you have a patient and in the moment, you be like, hey, I know exactly what you need. Of course, creating a safe environment. So, you know, at a primary care office or in a waiting room, it can be nerve-wracking for folks because they're probably already afraid to talk about things, especially with certain providers or certain people. So putting out flyers, literature about harm reduction in general may kind of make them a little more comfortable that you're willing to be open and talk about it, that you're okay with this stuff, that you know a little bit about it. And then having maybe Narcan, fentanyl test strips, cookers, whatever you're comfortable with having in your practice, may also be beneficial just to kind of build that trust and rapport, and that, hey, we're here to help, and here's some resources. Okay, so we're gonna go into like breakout rooms. I believe Joe's gonna help me with that. And so basically in your breakout rooms, I just want you to guys kind of talk about wherever you guys are in your practice, how do you plan or how will you implement harm reduction practices? Or even if you are doing them, what's worked for you, what hasn't worked? So hopefully you guys got to meet some new folks. I know a lot of people are also working together. So what I did want to say too was in regard, like kind of going a little backtracking, just is, you know, in regards to also learning about available resources. Also, I just also want to say too, like working with folks, like knowing your resources, also knowing like what insurance covers, how the referral process works, the criteria, and that kind of thing. So I think too, learning more about that stuff so that you're not kind of promising some sort of form of treatment and maybe they're not eligible for that, and not promising certain things is really important. I just had a light bulb moment after we broke up. So so I just kind of figuring out those steps too, and just really educating yourself. So let's move forward. So let's kind of talk a little bit about substances in society and kind of our perceptions about them. So this is obviously just a grid of what's acceptable, what's a little gray, what's unacceptable. So obviously like caffeine, sugar, even alcohol, I think is a lot more acceptable than meth, heroin, coke, that misusing prescriptions, because, you know, we forget about cross addiction. So reminding people, you know, who are in early recovery or wanting to be in recovery to not replace it with caffeine, sugar, or another actual substance, I think is really important. But it also kind of just shows you what society actually thinks too, what's acceptable and what's not, and that how that kind of makes certain folks feel when they're using a certain substance. In the gray area, we put in prescription opioids, and just because I think people who have chronic pain are feeling a little gray in the sense that we are much more harsher on how often people can get opiate prescriptions, how long can they have them on, all that stuff. Smoking cigarettes, I think, is still a little gray. I think we're leaning more into unacceptable as the years go on, but I still think it's a little gray. And then marijuana, legalizing it, all that stuff, I think is huge. I also want to say too, you know, like with the recent news in Oregon, they just passed a law yesterday about decriminalizing all drugs, and including hard drugs, so including heroin, cocaine, crystal meth. And basically what I was reading is that they are planning to, if you're caught with a certain amount, if it's a small amount, they basically will fine you $100, and then with the revenue that they were getting from medical marijuana or recreational marijuana, they're going to try and send those folks to treatment instead of incarceration. So I think that's really interesting, and how the gray areas are kind of like marijuana can maybe weirdly help us with our substance use disorders. So this is just a little narrative. So a man is taking a plane trip and is terrified of flying. He takes some of his partner's prescription Klonopin before getting on the plane, and he stays calm throughout the flight. The medication has worn off by the time that they land. I'm curious, and anybody can speak up, if do you think this person has a substance use disorder, or is this problematic?
I mean, I'll say it's problematic, but I don't know if without enough context, it's hard to say if this is a substance use disorder.
Absolutely. Yeah. I think that this story, this little small narrative without much detail or context kind of shows you the importance of a good assessment is a good motivational interviewing skills, and really figuring out if this is misuse just because, hey, I got some serious anxiety on a plane. My partner's like, here, I'm fine. And I never take a Klonopin throughout the year, except that one time a year I'm on a plane. Could be risky just because benzos can be risky, but it's figuring out the difference between use and misuse and dependence, really. So this is just kind of following up on our previous slide about what's acceptable. So, you know, we can kind of come up with different things like, oh, it's just a cup of coffee. Sugar, it's in everything pretty much. Alcohol, you'd be like, hey, I was a binge drinker, but oh, I slowed down. Prescription opioids are prescribed all the time for post-operative surgery or any injuries. Marijuana is now used medicinally for like cancer. Some people are one-time users. Misused prescriptions can also just be like college Adderall use. So it's just kind of in context and how we can kind of understand substances a little more without jumping to dependence addiction. So this is the basic substance use is and what it isn't. So, you know, substance use is it's use that does not reach the threshold of an actual disorder, which we'll go over what the actual disorder is in the DSM. It could be recreational use. Substance use is not synonymous with addiction. I think a lot of people kind of get that confused because we worry about recreational use or random use because of how it could turn into something, but we can't jump to conclusions or assumptions. But it's something that longitudinally should be assessed or discussed. It's not always a serious health problem, and substance use is not always a disorder or dependency, right? And like I said, we'll go into more of what that actually is. But first, this is a really interesting graph. It kind of just represents a use and misuse. So look how like heroin, the 23%, that's how much people will become dependent on heroin, whereas the green is people have used but haven't gotten dependent. So really just shows in context how many people will be affected by using and how risky it can be. So everybody's favorite book, the DSM-5. So obviously, as we know with the DSM-5, it changed from abuse to, you know, mild, moderate, severe. So it's a spectrum now. And you need a host of criteria to meet, whether it be a mild, moderate, or severe. What is interesting that I have kind of run into in the hospital setting is trying to differentiate people on pain meds and addiction. So if they need them or not, or if there's an addiction component, because as you see, like 2 of the DSM-5 criteria is tolerance and withdrawal. So if I'm on chronic pain meds, I'm going to have automatically those 2, because if I stop my pain meds, I will go into withdrawal. And of course, over time, as we know with opiates, we begin to build a tolerance where we do tend to need a little bit more because there is a ceiling effect. So here's just another kind of way to kind of see the spectrum and how many criteria you need to in order to diagnose someone with a mild or moderate or severe substance use disorder. I think this is a really interesting and big topic that we should kind of focus on too, as we kind of slow into our like the end of the presentation, is how COVID really has impacted the opioid use epidemic and just substance use in general, I think, not even just opiates. So here are just kind of some there's been a lot of innovative ways to reach out to those who are in recovery or trying to be in recovery. So this number right here, the 401-606-5456, that's actually our Buprenorphine Hotline. So if somebody who's struggling with an opioid use disorder and is wanting I need a script of Suboxone because I don't want to use, I don't want to relapse or return to use. See, I even do it. You can call that. A doctor who is X-waivered for Suboxone can help you and then send over a script and educate on how to take that medication without precipitating withdrawal or anything like that. Another great thing is loosening of the policies on the opioid disorder treatment requirements. This also is just for substances in general, actually. So in my position, I try and do a lot of referrals to inpatient programs for residential, and prior authorizations are so much easier and it's been amazing. It's a lot less of a hassle. They're willing to kind of just be flexible, even if a patient's been in treatment earlier that month and then they kind of either left AMA or something like that, but wants to go to a different program. It's been a lot easier, which I think is great. I will say too, the innovative ways is innovative, but also could be harmful too, but is like using Zoom for AA or Smart Recovery groups. I know Anchor Recovery Center does like had a Halloween bash on Zoom, that kind of thing. However, I have noticed working in the hospital setting is that, a lot of our folks have been hesitant to come to the hospital. So when COVID first hit, my census dropped really quickly. And then as things kind of started opening up again, man, did we get really busy. And it was because of people getting sicker because of their substance use, because they didn't seek out help in time, or two, because there have been new folks that are becoming addicted. A lot of new people struggling with alcohol because of being isolated, not working, they were laid off, they got a lot of time on their hands. So we're kind of seeing a big new wave of new folks. And then of course, as we've seen, like no in-person AA, NA, or Smart Recovery really. Even therapy and IOPs are a lot of virtual, which can be really difficult for those who are a little more oppressed that may or may not be tech savvy or don't have those resources. So that can be really difficult for those folks. So like I said, like I think too, like a lot of people miss the human connection of being face to face or being within their home groups. Can be really difficult. Increase in relapses, that's been huge. A lot of the methadone clinics have been giving are being a lot more lenient with take homes, especially for those that were 65 plus, just so that they were not waiting in line and being too close to other folks. And then obviously, like I said before, I think the isolation has been really hitting some folks really hard. Trying to figure out a savvy way to just support them during this time, because I think we're all feeling it in one way or another. So this was supposed to be another little video, but my computer won't play it. So it basically was about this young girl named Abby. She basically she's gone through an overdose, and she ended up getting Narcan, and it saved her life, and how she got that second chance motivated her to kind of seek out the treatment she needed. And then she ended up becoming a recovery specialist and like is paying it forward. So it was a really nice, sweet ending to kind of say like, hey, Narcan is a harm reduction model. It gave this woman a second chance, and see how she's paying forward to our community now. So these are acknowledgements. And then I'll kind of open up because I ended up ending a little early, but I want to respect people's time, but please ask questions, concerns, anything you guys need from me. I'm more than happy to answer them. No worries if you don't.
There's some people in the chat box if you want to check it out.
Box. I don't even know chat box. more. Oh, chat. Hi. Okay. Okay, we'll do any. Oh, Sublocade. Yeah. Now, Sublocade is a big thing, and I think it's going to get bigger. I think it's a great resource. I think a lot of our buprenorphine doctors, I'm not going to speak for them, I'm also not a doctor, but I think they're really new to the game too. And so it's just, it's a little harder to access, but we have a couple of docs within Lifespan that are doing it now, and I've heard really good results.
Hi, by the way. Actually, we've had really great results as well in the methadone OTP programs. Honestly, like it is a game changer, like long-acting injectable Suboxone.
Yeah, that's a harm reduction model.
Stolen. It can't be stolen. Well, it'd be really stupid to try, but the problem is like not a lot of providers know about it. Not a lot of people are also willing to register for the REMS because there's actually a risk mitigation system you have to go through, which is for like paperwork and then the prior authorizations. But honestly, like that's going to be the game changer probably in the next with the pandemic. I expect with the second surge. I'm just going to be honest with you. Like,
oh, for sure, absolutely. I think you're hitting the nail on the head because I think, you know, methadone and Suboxone are really great medications, but you know, if a patient that you're seeing or a client is really kind of not doing well with getting to the methadone clinic every day, or is kind of on and off the Suboxone because they're like, well, I'll use it and then maybe I'll, you know, they can kind of play around with it, which is okay. But the longer injectable is a safe way to kind of hone in on, okay, let's do this and see how this really impacts your recovery efforts and see if you're not, you know, kind of using sporadically. So yeah, I've seen some, it's getting bigger in Lifespan, but not quite as like, that's what we're doing.
One other thing I had to ask, what are you guys seeing as far as carfentanil positivity or the fentanyl analogs? Because we have been seeing that in Providence and in Woonsocket area. I know a lot of places aren't testing for it, but it takes sometimes up to 6 to 8 kits, up to 8 milligrams of Narcan just to revive somebody. Have you guys seen that over in Providence very much lately?
Yeah, I find that it goes through waves, where, and that's a really good point too, where the fentanyl strips, like it could not be fentanyl, but it could be carfentanil. So your test strip won't pick up on that, and there is no carfentanil test strip. So unless you do a urine tox screen, which yes, takes forever. So in the hospital setting, we would have to do a send out. And
on October 1st, he got a letter from Social Security saying that he still owes $1,129 from an old overpayment.
Someone might want to mute. But I have seen surges where my patients that I've seen where you're reading like the EMS reports or just like the emergency room notes before they land on a unit is, yeah, they needed heavy doses of Narcan, like multiple, and it's really hard to wake them up. So it is really scary. I haven't recently seen it too much now, but I want to say a couple months ago and like a year ago, it was getting a little wackadoodle. Mm-hmm. But if anybody, you know, I know Tammy wrote asking me for my contact information. I'm more than happy to outreach anybody, or if anybody has questions or concerns about resources or anything else, I'm more than happy to ask. But is there any more questions or topics or anything like that before I can let you run free? Okay. Joe, does anybody need to do anything else before we wrap up?
Sorry, was on mute again. So for those of you who don't have access to the chat box, if you weren't able to complete the pretest, do not worry about it, but please complete the post-test. The link is going to be sent out to you after the session. If you are attending as a physician, psychologist, or pharmacist, please contact me. If you're here for social work or nursing CEUs, just complete the post-test, and on the post-test, it will ask you which type of CEUs you want. But yeah, other than that, if you have any other questions, feel free to email me at jmartin19@lifespan.org. Should be all over everything you've received. But yeah, so that is all I have.
I appreciate you guys taking the time. This was really great. Thank you so much.